Yeah, so, all right, so what's up today? What we're talking about? We're continuing?
Yeah, we were talking about my friend last week and
Right.
her conditions that she's been dealing with, her issues that she's been dealing with in regards to her period, heavy, painful periods, painful sex, and we got into possible diagnosis. And this week we said we'd speak on, we got into investigation as well. So this week we said we'd speak more about treatments, right? I think that's where we were. Okay. Right.
Hello, everyone. This is Dr. C, and welcome to Women's Health with Kim and Dr. C. So, we're going to get into it today. How are you doing, Kim?
I am doing good. It's a good day, beautiful day, not too hot, not too cold.
So, what's trending now? I'm always interested in what's trending. Last week, I learned. What did I learn about last week?
Vabbing.
Vabbing was last
week. Vabbing.
So what's interesting today?
Well, interesting. What I saw a lot of on my timeline this week was a lot of vajacials. Do you know what vajacials are, Dr. C?
Vajacials, wow. Can't say I've heard of that one before. So I'm back in school again this week. Tell me about it. What's a so like between a mixture between facial and vagina. Is that what it is?
Exactly. That is exactly what it is. So it is a facial for the vagina. So basically, it's more like for the vulva, but you know how to use that word. So it's really them using different type of natural herbs, and like kind of a mask over the vulva. So that is, the outer part of the female reproductive organ. So they would put these natural herbs and chemicals to kind of peel off the vulva to basically help with ingrown hair, smoothness, and they usually follow it up after a wax. So after you wax, you do your vajacials, so you're nice and smooth, just like you would treat your face.
Oh wow! So they, what kind of herbs are they using? We're not sure. Is there any?
So I'm not too sure. I've never really gone in depth with it. I just see it all over the timeline. You see the pretty pink. They have rose ones. They have gold ones. They have all kind of fancy stuff that they're using. I've never gone really into it, but I know that the idea is to help with hyperpigmentation and to remove ingrown hair. So what I'm guessing they would be using probably turmeric, lime oil, and those things that are usually geared towards that. For me personally, I am as much as if you can avoid putting all these chemicals on your vagina, do that. But I mean, I'm all for empowerment. If it makes you feel empowered, it's not changing your pH, it's not doing anything to it. Hey. So I'm not against this one like vabbing. I'm not. I'm more well, if it works for you, go ahead, I'm always up for luxury.
Well, yeah, I think, the question really comes into what is in the what is in it that are being used, right? Yeah.
Yes.
I think that's going to be the key.
And whether or not these chemicals will affect your pH or throw off your balance.
Yeah, one pH, but also the vulval skin is quite sensitive, to chemicals. And so, you can easily have a situation where you're having inflammation setting in, and then you have women presenting later with, itching, burning, rashes in that area.
True.
So I think the key thing for that is going to be what's in the chemicals that they're using in the mask.
What's in the chemical? You know what? I'm going to tell you what's in the chemical next week. How about that?
Yeah, that sounds good. Well, assuming...
I'm going to tell you.
I'm sure people have different concoctions that they're using, but we'll be curious.
Yes, I'm sure. But I look at the main ingredients that, they probably use standard across the board. I'm sure they switch it up because I said I see the gold ones, I see rose ones, and they look really pretty. Of course, they look so pretty, so luxurious. You're like, oh my gosh, that looks nice. But at the same time, as a woman's health physio and someone who deals with women's health, I'm like, if you don't need to be putting that on your vagina, don't, But at the same time, I do get it. Women are taking time out to do something for themselves and do something for their vagina. I'm not going to fight it if it's not dangerous chemicals or chemicals that will cause them other problems in the long run.
All right. So I guess the conclusion here is make sure you know what is in the chemicals, right?
Absolutely.
So, I think I'm in the middle on this one. I don't see a problem, but certainly the important thing is to make sure we know what's in those chemicals. Eh?
I feel the same. I can agree with that. I'm definitely in the middle.
Yeah, so, all right. So what's up today? What we're talking about? We're continuing?
Yeah, we were talking about my friend last week and her conditions that she's been dealing with, her issues that she's been dealing with in regards to her period, heavy, painful periods, painful sex, and we got into possible diagnosis. And this week we said we'd speak on, we got into investigation as well. So this week we said we'd speak more about treatments, right? I think that's where we were, right?
Okay.
Am I right?
Yeah.
Yeah. All right.
Yeah, I think that's
so. We did get a little into treatment because we did speak about the laparoscopy and how it is for diagnosis and it can be for treatment as well. So we barely brushed on it. So we want to go full speed ahead now. Yeah,
indeed. I think last week, based on what we were hearing, it was sounding like she may have had endometriosis, eh?
Right, endometriosis was diagnosed really before.
Right, based on the symptom that she was having. Yeah, right. Okay. All right, so, let's get into talking about treatment. The treatment options, Kim, are quite varied, okay? So we can generally separate them into lifestyle-related treatment options, medical treatment options, and then we can talk about surgical treatment options. All right?
Right.
And the decision as to what is used quite often is dependent on each patient's symptoms and how badly their lifestyle is affected and what their personal goals are.
Right.
So let's talk first about lifestyle changes. We're going to discuss the options and then we're going to see which one probably would be best for your friend. Okay? All right. So when we talk about lifestyle, the evidence isn't strong, but we know that there is a benefit to general healthy lifestyle as it relates to nutrition, meaning that whole food nutrition, low saturated fat, low carbohydrate, as in processed foods and so forth, generally is considered advantageous, which is true from almost any condition you can think.
Right, absolutely. So you said the evidence is low for this. Is it because we don't have enough research, or it's because we don't have enough research?
Probably a combination of factors, and sometimes because this endometriosis is such a chronic condition, it's hard to find studies that are going to look at nutrition and so forth over a long haul. And generally the effects of lifestyle changes are seen with consistency, not just a short-term diet.
Absolutely. And normally in conjunction with other treatment options as well.
That's right. That's the other thing. Right. How do you separate the benefit of one versus the other?
Right.
Exercise generally is something advantageous and has been shown to have benefit in women, not just with endometriosis, but any chronic pain disorder. Incorporating low impact exercise, cardio, and so forth is to your advantage. Though we talk about options of medical treatment now, we're talking about we can divide that into hormonal and non-hormonal treatment options, right? And when we talk about the non-hormonal ones, we usually are referring primarily to pain medications, right? Of which you have those that are specifically like anti-inflammatories. And then, we have a whole host of those. The ibuprofen, for example, is a common one that you find in many brands. Diclofenac, you see in some brands as well.
Right.
All right. So these are pain medications. And then you have a group of pain medications that are not really anti-inflammatory, but they actually have an effect on the nerves and dealing with nerve-related pain. All right.
Got it.
So that those are the non-hormonal options for the most part. And then we get into the hormonal options, right? And these are by far the more popular group as it relates to treatment of endometriosis. And how I like to describe it is that the hormonal options pretty much put a woman or trick a woman's body into feeling as if she is at a stage in her life where she would not be at risk for endometriosis. So let me put it this way. Who are the women who would not have, a risk of endometriosis related symptoms?
Somebody who's pregnant.
When in a woman's life. Yeah, so when she's pregnant
or menopausal.
Right. So if she's pregnant or she's menopausal, right?
Because she's not having any periods.
Exactly. And remember what we said, that it's really that hormonal effect on the lining of the womb and the shedding that causes the inflammation, right?
Got it.
Right. So generally the main drugs can fall into those categories. There is a group of drugs that actually simulate the male state. And these are testosterone-like substances, but we really don't use them a lot for obvious reasons.
Right.
To go into that.
Deep voice and some hair in case that you don't want hair. I'll pass on the testosterone.
Right. So we talk about them, but they're not, hardly anybody uses those. So we're going to focus on the two.
In what case would you use that though? In what case would you choose that over all the other options that you listed so far?
Well, that's a good question, Kim, because the truth is, I've never used testosterone analog, and I imagine that if I ask most gynecologists, they're going to say the same thing, because most of the time you can achieve successful treatment by other means
without
than putting a woman through that effect,
Because, wake up like this.
Yeah, but even before you get to the deep voice, you have acne, the skin gets oily, and it can be a real mess. So it's very, even in the past, but not so much anymore. And
we already have conditions that help us, that does that in women, like PCOS.
Like PCOS, right? So,
right.
We really
don't want that.
Exactly.
Yeah.
So the main ones are the first two. So the ones that kind of simulate pregnancy, these are usually either progesterone based or it's a combination of progesterone and estrogen, right? Because those are the two main hormones that are high levels in pregnancy. So, and those can be given either in different forms. So the difference is just how it's given. So for example, you have pills. Right, so oral contraceptive pills, for example, are used commonly in this setting for in women with endometriosis, and those are taken. Sometimes, we either may take them as normal in cycles and breaking, or we take them continuously. We recommend taking them continuously, and in severe cases, we generally recommend continuous treatment. Right. And then now,
what would be the reason for breaking?
Yeah, so normally oral contraceptives you break, right? To facilitate the menses, right? So
yes,
normally, pills are designed that way. So you have active pills, and then you have a pill-free, hormone-free period where they either give you a placebo or you don't take anything, and that allows the period to come. Right. And the truth is, it's really more of a psychological benefit for women who are accustomed to seeing their period. It's not so much a medical benefit,
I always wonder because I'm like, if my period is causing me so much pain, why should the treatment also include me seeing my period? I would just want to skip it. I'd be like, yep, pill done today, start pill tomorrow, because I would just not want to. So I was wondering if that was it. Some women just want to see their period. They just want to know that it's there, it's still coming. Because some people think that if they're not in a period, they're not healthy. They have trapped blood. I've heard all kinds of things where that is concerned. So I was wondering if it was the doctor saying, hey, pause, let's see a period, or it's just women, or it's just for the women.
Yeah, you're right. Because remember, when OCPs were originally designed, as it says, oral contraceptive pills, they were designed primarily for contraceptive benefit. And at that point in time, it would have been hard to convince women that it was normal for them not to see a period, that it was okay, rather, for them not to see a period on the pills.
It was a marketing technique.
Yeah, so it looks normal and everything is normal. And then, you have some women who actually feel that if the blood is, if not seeing a period, there is blood backing up on the inside.
Right.
It actually becomes a source of worry. But in actual fact, what happens if you continuously take the pill is that it just makes the lining of the womb so thin that it really doesn't shed, which is different from a woman who is not seeing her period and is not on pills. If a woman is not on any medication and not seeing her period, then that's a problem, But on the pills, it's different. So in endometriosis, sometimes the recommendation by the doctor may be to continue it without breaking, or if you break, it will probably break like 3 or so times a year, 3 or 4 times a year at most.
Got it.
Right. All right. So the other way of delivering the hormones in the case of progesterone might be by an injection. So, for example, your common injection is the Depo-Provera injection, which is depomedroxyprogesterone acetate, which is given once every 3 months. Or we can use, for example, an intrauterine system. Okay, so the intrauterine system is basically a small T-shaped flexible device that is placed inside the womb. It stays there inside the womb and it gradually releases the hormones directly into the lining of the womb. All right? And there are different types. I mean, we don't want to use too many brand names, but the Mirena, for example, is the most commonly circulated type of intrauterine system.
Okay.
All right? So those are those that actually simulate the effect of pregnancy to some extent. Then we're going to go into the ones that simulate menopause, right? And the most commonly used drugs in this category are what we call GnRH analogs. And these are essentially medicines that block the stimulation of the ovaries. And so by blocking the stimulation of the ovaries, they prevent the ovaries from producing the estrogen that is going to feed the endometriotic deposits. All right? And that makes sense because remember we said that's what's feeding the endometriosis. So that's the reason why women, when they get into menopause, the endometriosis goes away because the estrogen levels fall. So these drugs do that, Yeah, so obviously all of these drugs have advantages and disadvantages.
Right. Because I was wondering, why would you choose the pills that would mimic pregnancy versus the ones that would mimic menopause? What would be the reason? Is that decided that factors like age, how old the woman is, are her goals? What do you use to decide which option to go with?
Yeah, so that's a good point. So a lot of it has to do with one, severity of symptoms, and two, what has been tried before, right?
Okay.
So take for example, if a woman has been on, most women by the time they get to the gynecologist, they've been taking pain medications for their periods anyway.
Got
right?
it.
So the fact that they're there is telling you that they're probably not getting good enough control with the pain medications. And so most commonly, most times you will find that you will start with, for example, oral contraceptive pills, right? Or progesterone only pills, because those are easy to start, right? You don't need any procedures to do it. You don't need not an injection. You just start pills.
Right.
And it's easy to stop if the patient has any unwanted side effects, right?
Yeah.
Because these drugs come, with side effects, nausea, bloating. Some women may experience, gastrointestinal disturbances, diarrhea, headaches, weight gain. So the reality of it is that, and not everybody experiences that, but those are things that patient has to be aware of as possibilities.
Right.
All right. So now, if, for example, you find that there is poor response to the oral contraceptives or progesterone only pills, depending on what you choose, then there may be a role for going for the menopause inducing agents, which usually come as injections, right? So, so those now may become second line agents, right? For persons who don't respond initially. Sometimes, certainly in my practice, what I've done is I've used them upfront in some cases. So if patients, for example, have large or extensive deposits of endometriosis, use the GnRH analogs, induce menopause to shrink down deposits, and then now start the oral, the progesterone, either like put in an intrauterine system or switch over to something oral or injector, So that's one option. One of the things that's important to state, though, is that the drugs that induce menopause should not be used. There's a limitation in terms of time frame. Okay.
Right.
Right, because these drugs are particularly, so apart from having menopausal symptoms, which can be a little bothersome, hot flashes, vaginal dryness,
anxiety,
irritability. Yeah, some women don't tolerate it very well.
Yeah.
But over time, the bones, you can get osteoporosis, bone loss.
Right.
Right, and even though it recovers once you stop the medications, you don't want it. Generally, that after 6 months, you have to either consider stopping them or adding something that is going to build back the bones. All right.
Okay.
And usually that means adding, funny enough, adding some estrogen, right? Or progesterone with it. It's interesting because
that is very interesting.
Yeah. So this is actually called add-back therapy.
Is there a heart risk too? Because is there a risk for like heart disease as well with the menopause inducing?
Yeah, theoretically, but most of these women, as you know, are young women, and the duration of use is not that long. So even though we know that menopause overall is associated with an increased risk of heart disease, the risk related to a short-term course of a GnRH analog is not that great.
Good.
And certainly most times the benefit will outweigh the risk once these drugs are used appropriately.
All right.
So those are the medical options. All right. So let me give you some time to digest that before we
I'm telling you, it's a lot, but it's good stuff. It's good stuff because I didn't even realize that that option was available. The menopause induction option. I always, we always know about mimicking pregnancy and using those hormones that will help to stimulate pregnancy in the body. But I did not know that the menopause inducing option, and I can see how it works, especially how you said that, how you utilized in your clinic in most instances where you start off with the, what's the word? The analog? What's it again?
GnRH analogs.
GnRH analog, right. The GnRH analogs, you would start off with that to try to reduce the size of the deposits and then switch over. And I can, especially where you have lots of migration, I can see where this would be extremely beneficial to the patient. The migration have anything to do with when you choose which one you start with, which option you'd start with?
When you say migration, what do you mean?
So last week you were saying that, the endometrial lining migrates to other areas. So that's when you would have the pain. So I was wondering if the patient has more migration, if you'd work more with that option versus just starting with the contraceptives.
Yeah, it depends, because one of the things you find, Kim, is that sometimes even though I said the extent of the deposits and how extensive it is, it's funny because sometimes patients can have extensive disease with only mild symptoms.
Right.
And sometimes they can have mild disease with severe symptoms. You understand?
Mm-hmm. Yeah.
So it's not always simple. That's the reason why you need somebody who's trained. You need a gynecologist.
Absolutely.
That's why this kind of it's important for your patient, for our audience to understand that this information is not meant to replace a good doctor.
It cannot.
It is right, because there are certain little nuances. Right.
But I think it will. I'm hoping that it opens their eyes to the thought process and all that has to go into choosing the treatment. So it's one thing to know the treatment options, but there are other factors that will determine what treatment option you'd go with. And our mind, that's not the mind of an OBGYN. I don't think we're able to decipher which treatment option to go with. There are just so many nuances.
Yeah, it depends on each case. And one of the things that happens as
Absolutely.
well, I find that, in this day and age, we live in a very, I guess, information somewhat creates much distrust.
Dr. Google.
There's a saying, when I was growing up, they used to say, little information is more dangerous than no information at all. Mm-hmm. Because sometimes having a little but not all, we become overconfident.
Right.
And the reason I'm saying it is because, like, for example, every now and then I'll have a patient and they will say, well, once we start talking, they say, well, doc, I don't want any hormone, and I'm not interested in any hormones in my body. And while I understand where it's coming from, I have to kind of caution them and say, well, I wouldn't be too quick to take that position. Right. Because depending on the severity of your condition and what's happening, there may be a role for that, if Absolutely. We're going to improve your quality of life. So what we have to be careful of is this culture of thinking that medicine is all evil. That's not true.
It's scary to hear people talk like that. They're like, "Oh no, I'm not just a doctor. I'm not just a doctor. Doctor just want to collect your money." And I'm like, "I'm sorry. I'm not going to invalidate your experience. I'm sorry if that's what you've experienced. But all doctors aren't like that. Right. Give another doctor a try. Do more research on the doctor before going." So that you're more confident. Just like you did research on Dr. Google, do some research on the doctor. Ask around, get opinions, get reviews. And then, you can probably try that doctor. But,
That's right.
it's unfair to group everybody and say, oh, all doctors are evil, or all doctors don't want to care about money, or whatever else they say.
Right, and also to tie the doctor's hands by saying, well, I'm not interested in this treatment versus that.
So like you're going to the doctor and you're deciding the treatment.
it can be, so it's important to keep an open mind and then get as much information before deciding, but don't close your mind. One of the important things is just to get as much information as possible.
And ask the doctor. Ask the doctor all those concerns that you have. you ask doctor, I've been in the hospital setting, and the patient will just finish talking to the doctor, and I come in as a physio to do the exercise, and they're asking me all these questions, and then I'm like, your doctor not just leave? Why you never ask the doctor? And like, I'm trying, but I really can't answer like the doctor. I can only answer from my point of view, the things that I am going to do and why I am going to do it and how that is important. The doctor knows what they're doing and the reason they're doing it. I am not the best one to explain that to you.
Yeah, it's true. But what happens sometimes, Kim, is that, I guess sometimes the doctors, we can be very intimidating. People can feel intimidated by the personality of the doctor. And, I guess their personalities are a little more open, more warm, and they feel more comfortable talking to you. But what I
really do try to answer.
You're right, but you're right. You said you have to be careful because you don't want to go outside.
I have to be right. My scope, and I see it happen a lot. Even outside of women's health, I had a patient recently, and I sent her to the orthopedic. Actually, I think that she needs to see the orthopedic surgeon because of what was happening with her knee. She went and she saw an old school orthopedic surgeon, and she came back and she's like, "I'm so displeased." I didn't send her to that doctor. Her friend recommended, and she went. She's like, "I'm so displeased with the doctor. I know if I even walked past him, he wouldn't even know what I look like. He never looked at me, not once. No eye contact." Whoa. And she was really genuinely upset about it. So I sent her to another orthopedic doctor, and she came back, and the orthopedic doctor literally said the same thing that the other doctor said and I said, but she felt so much better and nothing changed. Her diagnosis is still the same. The treatment that she has to do, it's still the same, but how it was delivered was different, and she felt better about it. So that's another thing we can share with our colleagues.
Yeah, I think that's true. And, hopefully that, that can improve. I don't know how, but because that is personal, interpersonal. Some people, even doctors, do have their own challenges, but what I hope we can achieve here, just like the same dysfunctionalities that others have, doctors do have as well.
Exactly.
But one of the things that I'm hoping that we can achieve with what we're doing is really providing enough information to our audience and to women so that when they do have interactions, they know what questions to ask, and they know what they should expect. So that's what I'm hoping.
Absolutely.
Yeah. So you want us to talk about the surgical part of it?
I think we've digested. I think we should get into the surgical. I think we have enough time. Yeah, let's get into the surgical.
Okay. All right. So why? No, the question is going to be now who and why, as it relates to surgery.
Yeah.
So before we get into the who and why, what do we mean when we say surgery? And so surgery just simply means that we're going to make an incision usually to either go in, look and remove whatever deposits that might be there. That it might range from just removing the endometrial deposits, or it may involve something more extensive like hysterectomy or removal of an ovarian cyst. It just depends on what the situation is. So who are the women, who are the persons who would qualify? And then, of course, the surgery depends on the route of surgery is also important. So we can either do laparoscopic surgery, which sometimes they call keyhole surgery, which is where we use a camera and, small incisions in the abdomen, as opposed to a laparotomy, which is where we're using a cut, a larger incision in the abdomen. So those are the two routes. All right. So who are the candidates? So for example, I would probably say you have three main candidates for surgery. Okay. The first group are patients for whom medical treatment is unacceptable. All right.
Okay.
And this falls into one of two categories. These are persons who either cannot, for whatever reason, take hormonal treatment, or persons, meaning that there's a medical reason, right? They can't take hormonal treatment, or let's say they're interested in getting pregnant. Okay, so
yes,
if you think about it, all of the things that I told you before, none of them were consistent with fertility, right?
With one,
so all
right?
of them had a contraceptive effect, except for the pain medications, of course. So if you're going to be on OCP, oral contraceptive pills, progesterone pills, you're going to put in an intrauterine system, whichever one you choose, or you're doing a GnRH analog therapy. All of those are associated with a contraceptive effect, meaning that while you're on the treatment, you can't get pregnant. And so for women who
so again, it comes back to the goals.
Yeah, their goals now. So their immediate fertility desires, then those patients, you would definitely perhaps consider a surgical option up front if it is that their symptoms are severe. It's particularly beneficial in the sense of fertility because sometimes the endometriosis may affect their ability to conceive. So in about 20-30% of women with infertility, you will also find that they also have endometriosis. I don't know if you knew that.
Right. Oh, no, I didn't. I did not.
So the benefit of surgery, because for a couple of reasons. One is that the inflammation that's caused by the endometriosis is believed to affect implantation of eggs, fertilization, and those things, right? And also because of the fact that the scarring that is caused by the chronic inflammation of endometriosis can cause damage to the tubes and can distort the relationship.
And physiotherapy can help with that.
Certainly, yes. I mean, you can tell us about that. Probably
there's actually good research.
Well,
go ahead.
Let's switch positions for now.
You want to talk about now? You don't want to go into the surgery.
All right. Let's talk about it
so physiotherapy. Yeah, we'll talk about it after, man.
You sure? Okay.
Just keep the surgery talk going.
Keep the surgery talk going. Yeah.
Right.
So
we'll remember.
As long as you make sure, because I'm interested to hear that part too. So the surgery now has that. So surgery may have that benefit. So and usually, most commonly in this case, we probably choose the laparoscopic route because of the cosmetic benefit, as well as the surgeon, you get more magnification of the tissue. So there's a lot of dissection sometimes that you have to do, and it may be a little bit better. All right. The other case where you may find that surgery will come up as being important would be the patient who, for example, has a large, a collection. So sometimes endometriosis can get embedded in the ovaries, and you can have the ovaries being, a large cyst being formed in the ovary. That's basically just old blood that's collected in the ovary. We call this an endometrioma. And sometimes you can have that in different places. And so those type of cysts, those type of ovarian cysts generally will not go away on their own. So, so most cysts that women talk about ovarian cysts all the time, and there's this obsession, who have cysts. Most cysts are not, usually harmful, and they tend to go away by themselves. Endometriomas, on the other hand, they just tend to continue getting bigger and bigger and bigger. Right? And so generally, once they get to about 5 centimeters or more, it might be beneficial to just have them removed, because now not only can they cause pain, but you can have what we call torsion as well, which is where the ovary twists on itself. And, a woman can literally lose her ovary because it cuts out the blood supply. So that's another situation. Yeah.
That's sad.
Very, but most of the time we're able to catch it before.
That's tragic. Yeah. So
then now, then the other category, which is the third group now, are women who, one are perhaps either past childbearing or have no future fertility desires, who also have had poor response to the medical options for treatment. So in other words,
Okay.
you have tried everything and it's just not working. All right? And these are sometimes women who may even have had surgery before, because surgery doesn't always cure the symptoms. All right? And even if the symptoms go away, the evidence shows that probably by 2 years or so, up to 50% of women will have symptoms again.
Can return.
Right, because remember, it's a chronic thing.
That's tragic.
So this group of women now, women say, well, listen, doc, I don't want to have any kids, or I don't want any more kids. So not working, just listen to me. Take it out. And this is surgery. Now where, so this is where we talk about curative surgery now. And curative surgery in the case of endometriosis usually involves hysterectomy plus removal of both ovaries. Right? And removal of ovaries is important because your aim is to remove the hormones. Eh?
The hormones.
Right.
Right.
Yeah. So that's usually a last resort for after you've done all you can,
Right. So it's like trying to hold on to, because it is very emotional to lose your female reproductive organs. It's like taking away your identity almost. So it's a very emotional surgery that I find. Because my patients come in after hysterectomy, they usually have a lot of, it's usually emotional for them to even speak about, So it's not one of those surgeries, like, it's very common. So people think, oh, yeah, man, my grandmother do it, my auntie do it, and don't worry yourself. But
indeed,
it doesn't take away from what it is. Yeah, it doesn't take away from that.
It's true.
I want to ask you something.
It's quite traumatic. Sorry,
yeah, it is. It can be. I know for me it would be traumatic. I know. I'd be like,
but it depends, Kim, on what stage you are. It depends on what stage you are, though. It depends on what stage you are.
Like at the stage where I'm just tired of the pain. If I had pain all my life with endometriosis, I'd probably be very happy to get rid of it.
Right.
But
some women are. Some women are like that. Listen, I'm over this. I'm not into the hanging on, So each person is different. And that's the reason why.
No, because you can want to get rid of it and it's still emotional. Like, I kind of want to do it because I want to get rid of the pain, but it's still emotional. It's still a part of me gone. So it's not one or the other.
It's true. It's true that you do have that, but then at the same time, you do have some women, and I'm just telling you from my experience, who who really don't have no regrets. I mean, they're as happy as can be, I have patients who come in and say, Doc, I don't know why I never did this long time. All of this suffering I'm suffering. I'm free. I don't have to worry about anything. I'm not worried about pregnancy. I'm not worried about, sex is good for them now because it's no longer painful.
I was just about to say that. I had a patient and she's like, I don't know. She said that she doesn't know that if it's the fact that she can't ever get pregnant, why the sex feels so good now. But sex has improved like 100% after her hysterectomy.
Yep.
She's like, I don't know, but listen.
So to each his own.
It's not all bad, and that's the reason why you can't just rule something out. Like, no, sir, no, doc. From your talk about taking out my womb, conversation done. Like, you never know how it's going to work out for you.
Right.
You don't know. So you have to have the conversation. You have to have all the cards out on the table, all the options available to you, so that you can make the most informed decision.
Right.
And I hope that's what people are taking away from our talk today. Like, we want you to make the best decision for you, not the best decision for the doctor, not the best decision that you hear says somebody else did for them, that worked for them, but the best decision for you.
That's right. That's right.
I want to ask you a question though.
Sure.
For patients with endometriosis who they get pregnant, have you noticed any? And it's not research based, but based on just experience, have you noticed any changes that they report after giving birth? Because a lot of persons like growing up, I always hear the women who had painful period, oh, labor going to be easier for them, and don't worry, your period going to get better after pregnancy. I've heard that. So in your experience, have you seen this happening as well?
Yeah, I mean, yeah, that's a good point, Kim, and it's fairly well thought of, and I'm sure most of us would agree to some extent that many of our patients would report improvements after, certainly from endometriosis-related pain.
Right, endometriosis.
Yeah, and if you think about it, it makes sense that would happen because of what I told you about the treatments that we use, right?
Right,
so,
right.
Yeah, so essentially for 9
it's
been
months, naturally happening for 9 months, right?
Yeah, for 9 months. And so these endometrial deposits are undergoing, that thinning effect from just this continuous exposure to progesterone.
Right.
And so that may be a part of it. Also the fact that the womb is growing, as it grows out of the pelvis, it stretches some of the scar tissue that might be there and loosens up some of the scar tissue. So that could also be a factor. So that by the time the womb comes back down, it's not as tied down as it was before. So yeah, certainly. Not saying that you should go and get pregnant just to treat endometriosis.
I'm sure it's a thought. But we're not self-treating, guys. We're not self-treating. As we said earlier, we're not self-treating. We're going to the doctor. Right. We're going to get the doctor's opinion. Right. Absolutely. Absolutely.
Right.
All right, Doc. I think we're at the end of today's session. It was a good one. So let's wrap up.
So let me ask you.
3. Okay,
you're going to tell me the takeaways now. Let's see who was listening.
So I'm gonna give you the takeaways. Okay, I'm gonna give you the takeaways. So there are 3 categories of treatment for endometriosis, and this includes pain, painkillers, or just treatment exclusively for the pain. So ibuprofen, your anti-inflammatory drugs to help reduce the pain. And then we have hormone treatment, and the hormone treatment can go into 2 categories, and that is the hormone treatment that mimics pregnancy and the hormone treatments that mimics menopause, right? I'm going good, Dad. And then you have the surgical treatment, and when it comes down to surgery now, we are looking at who and why, and as well as the patient's goals, right? That's so patients who would like to get pregnant now, but their endometriosis has caused changes in the uterus. They have these changes that would prevent pregnancy. You'd have to go in and remove them so that we can facilitate pregnancy as much as possible. And then you have those persons who they've been treated for so long and they're not having any results, and they say, hey, you know what, get rid of it, take it all out, I'm done. And then you remove the uterus along with the ovaries so that you don't have these hormones being produced anymore and can fully correct the endometriosis. Did I do it? Did I do it?
Check. A class, A student. That's good stuff. Yeah.
But I will follow up with the physiotherapy management. I will start it off in our next session.
Yeah, next session.
So you have to come back for it. You have to come back and hear how physiotherapy can help.
Okay. All right, guys, you hear that? So that's the teaser for the next session of Women's Health with Kim and Dr. C. I'm Dr. C. And
I'm Kim.
All right, guys. All right. Peace out until the next time.
A BP.
I think that's my phone.
So can That's fine. Yeah. So I learned a lot. So I'm hoping that we're